Thank you. At the outset, I thank Professor Arun Garg for giving this opportunity. So I want to start with a disclaimer. The chairperson said that this is a clinically isolated syndrome. So what do you mean by that? That most of the time these patients end up just being treated with steroids. Let us wait for the next attack. So I'm basically more of a non-conservative person. So I'm going to disprove those things, especially in the next few minutes. So this is basically going to be a case-based approach. This is what Dr. Arun wanted. So let me start with the first case. This was a 20-year-old gentleman who came with a history of painful bilateral vision, right followed by left, and his visual acuity was right 6/36, left was 6/60. These are his MRI. I will talk about the MRI. So this was his eye. So you can see the RAPD which is present. So you can see in the left eye especially, there is an escape which happens, the pupillary escape phenomenon which happens. So this is the RAPD, pupillary escape phenomenon which happens. So if you now look into this MRI, so most of the time what we do is usually we just try to see what is happening with the patient and do. Now the MRI, especially in immunology, has evolved into such an extent that just by seeing the MRI, we'll be able to even tell what could be the antibody. So if you look at this, he had right followed by left. So if you can see here, the right optic nerve clean, but can you see here the left optic nerve is not clean. So here you have a fat stranding which is present. So this is usually seen in a MOG-associated optic neuritis. So even without the antibody, you will be able to make out. See here, it's a long segment optic neuritis which is present and the fat stranding which is present. So this was a case of a first episode of optic neuritis, but MRI-wise, which looked like MOG. This is another patient with RAPD. What I wanted to show the RAPD is basically what happens is most of the time you may have just a one episode which is on one side, but sometimes when you look for the this pupillary escape phenomenon, you may see it bilaterally, and that is very, very sensitive, especially to pick up the bilateral involvement of the optic nerve. So we know that the classical triad of optic neuritis is the visual loss, eye pain. Eye pain is very, very classical. In fact, even before the episode of optic neuritis, most of these patients come with history of pain which comes, and then there is a visual dysfunction which is very classical, and especially it will be very helpful when it comes when you taper the steroids, that you know that you should not be tapering the steroids. So among all the classical symptoms, eye pain is the most classical, especially in optic neuritis. So now this patient, she's telling something. The audio. Okay, basically I wanted to show, this is not very classical, but we have heard of the phenomenon of phosphenes. We know that Lermit's...
From this part of my eye, I was able to see some light-like thing, like a flashlight thing I used to come. Slowly, like after 1 week, it gradually started with fading of my eye, like blackness started coming, and slowly my vision started reducing. So now it's like left eye I am visible, right eye I am not able to see. Slightly some movement is there from this part only, that is from here I'm
So
able to
if
see
you actually see what she said, it was basically that she had some flash-like light which was there, and after that she developed the visual disturbances. So this is very classically called as phosphenes, which are very, very important. Just like eye pain which is there, even the phosphenes. We know about the Lermit sign in spinal cord. We also have these phosphenes which happens when there is a optic neuritis. So during optic neuritis, if your fundus is normal, it is usually called as retrobulbar, but if your fundus is affected, it is called as papillitis. Now let me go to the next case. So this was a 62-year-old gentleman. He was a diabetic. He noticed decreased vision in the right eye, noticed when he got up from sleep in the morning. There was no progression, but the right eye was affected. Its severity was the most severe as soon as he got up. So visual acuity was right by 6/24, left by 6/9, fundus was normal, no other focal neurological deficits. So what is the diagnosis in this patient? AION. What was the clue in this? Yes? He has sleep apnea too. Okay, I didn't take that history. Next time I will take that history. So basically, this is one of the classical symptoms which happens. Getting up from sleep, developing the most severe type of visual disturbances, and remaining static. Most of the time, this is very classically seen in AION. And the other clue in the history was about being diabetic, age. That also contributes in telling that it could be AION. So once you diagnose it as AION, any test you want to do so that it will clinch your diagnosis? Sometimes that may not be possible in all the cases. Most important is the visual field. That is most of the time missed in most of the patients, but visual field gives you a clue, especially when there is, when it is pertaining to the horizontal meridian. That gives you a clue that it could be a vascular, because many patients have seen who have been treated with steroids as optic neuritis, but they come to you, but we see that the visual field very nicely it will have this horizontal meridian being cut off. So this is very important. We do not ask for it. Yes, you spoke about fluorescent angiography. Yes, it helps, but before that also we can go for the visual field, which gives you the clue that it could be a vascular etiology. So if you actually see the visual field, the A and the B, these are the most common visual field which you see in optic neuritis. So when you have this type of temporal or bitemporal, where you have a horizontal meridian being cut off, this is called, this is more in cases of a visual case because of a vascular etiology. So always remember, when the patient comes to you, one of the clue is if they have a vascular risk factors. Otherwise, especially when they have got up from sleep and they have noticed some fading of vision, that is also one of the clue which tells you that it is a vascular etiology. So there are a lot of other to go into typical and atypical. I'm not going into this, but I just wanted to stress upon these things also. Sometimes what happens, neuroretinitis, especially because of in India, infections are so common, and you can have a neuroretinitis which can be mistaken as a optic neuritis. So what happens is, that time it is a fundus which is most important. They also come to you with visual disturbances, but it is a fundus which gives you a clue whether it is optic neuritis or neuroretinitis. So please look for that. And now evolving, MRI has evolved so much, like what I showed you in the previous this one. Here you can see in the first one, it is bilateral, left more than right, and you can see here the long segment which involvement, and here it is going up to the optic chiasma. So these are all very important, because sometimes when we send the antibodies, it takes 4 to 5 days, sometimes weeks or 2 weeks to get the antibodies. But the MRI, the moment you do, you may be able to subtype as to what is the type of optic neuritis. So when you do the MRI, you'll have to divide it into 4 parts, the optic nerve, and if more than 2 by 4 is involved, it's called as long segment. Just like how you have a long segment myelopathy, you also have a long segment in optic neuritis. More than 2 out of 4 is involved, it is called as long segment, and that goes more in favor of NMO spectrum disorders, MOG spectrum disorders. And as this diagram shows, if it goes towards the chiasma, it goes towards the NMO, and more towards the eye, that is the retrobulbar, is MOG like disorder. So if you see this paper where they did about what is the different types of optic neuritis, so these all patients were those who actually came with the first episode of optic neuritis, but you can see them that 57 were percentage of them were actually turned out to be multiple sclerosis. This is also a big study which is done from South India by Lekha Pandit. You can see here nearly around 70 to 80% of them, they all came with the first episode of optic neuritis, but turned out to be some primary or a secondary demyelination. So same thing happens even in neuromyelitis optica. Among the 6 core features, optic neuritis is one of the most common feature which happens in nearly 80% of the patients. So that is the reason that in the first episode, if you have ruled out vascular, if you have ruled out infective causes, and you have made a diagnosis of primary demyelination, and if you are able to subtype as to what type of demyelination it is based on the MRI, even if your antibodies are positive or not, you should be treating these patients with long-term immunomodulation. And same thing with MOG related disorders. Of course, MOG related disorders are not the same thing because they are slightly different. You have a subtype of MOG related optic neuritis, which could be just a post infectious or post vaccinal. They can be monophasic. So, if you rule out these monophasic forms, the rest of them, yes, will require a long term medications. Apart from this, we can also have other immune mediated optic neuritis. I'm not going into the details, but basically what I want to tell is optic neuritis is one of the most common clinical features in most of the primary demyelinating disorders. But before you make a diagnosis of optic neuritis, always rule out that it is vascular. You have a lot of bedside tests which you can be doing to see that it is vascular or a demyelination. And once you have confirmed the demyelination, take your ancillary tests, take your MRI, take your visual fields, which gives you a clue as to what type of demyelination it is. And even before your antibodies come, you can make a bedside diagnosis and start these patients on treatment. So now coming to the cases on myelopathy. So this was a basically the topic was long segment myelopathy, but I'm just going to show you as to how to differentiate between the short segment and long segment. So if you see here, this was a 22-year-old girl. She had a history of paresthesias. She was actually suspected to have carpal tunnel syndrome. MRI was done. They thought it was normal. But actually, if you look at the MRI, there is a small hyperintensity, which is less than one segment or just one segment, which is there. So this was the one which was causing the paresthesias. So always remember there is something called as a myelopathy hand, which can be mistaken as a carpal tunnel syndrome, which can be mistaken as a radiculopathy. So one of the clue is when you're examining these patients, look whether there is a sensory dissociation, especially between the joint position vibration sense as well as the pain and touch. That gives you a clue whether it is a myelin or the peripheral nerve which is involved, which can make you not suspect the spinal cord. So this is an example of a short myelopathy. But when you see this, this was another man who actually came with the acute transverse myelitis. So see here, this is a long segment which is there. So whenever you have 3 and above, it is called as long segment myelopathy. And long segment myelopathy, especially if you have to see what is the severity which is there, when it is more than 3 segments, it is called as LETM. So let us see the next case. This is a 16-year-old boy who came with an acute onset of urinary dysfunction. Catheter was placed, and within 12 hours, he developed sensory changes, and within 24 hours, he became paralyzed almost 0/5. DTRs were absent in all 4 limbs. So this was the motor level above L1. So it was around the thoracic myelopathy which was there. And because you had reflexes which were absent in the 4 limbs and sensory level were higher, the diagnosis was cervical myelopathy. So if you see here, this there is a long segment which is involved. This is another man who came with 43-year-old history of lower limb weakness of 1 day duration. He suddenly developed sudden buckling of lower limb when he got up from the chair and complete weakness of the lower limb with 0/5 power. So if you see here, this spinal cord which is involved, it is easy to make a diagnosis of LETM because it is more than 3. But always look at even the axial segments, which gives you a clue. Here it was only the anterior segment, but also in the history, it was a very acute onset. It was sudden onset that he got up from the chair and sudden onset tuck. It was the whole complete paraplegia which he developed. So these are all the clues that it is not a demyelination but a vascular etiology. And when you have this type of a history, sometimes it may not be enough. If it is an extensive etiology, you need to ask for a diffusion restricted spine image because it shows a diffusion restriction, and then that will give you a clue it is a vascular etiology. Otherwise, what happens is you will end up treating them as long segment myelopathy and they will be on long term immunosuppressants for a long period of time. So imagine if this patient comes to us after 2-3 years or even after 2-3 months and you do the MRI, you will see the long segment myelopathy and you will see that there is an atrophy on that side, and you will think that it is a long segment myelopathy and start them on immunosuppressants. So always the history is very important. The acute onset which happened here and the first MRI shows you where the lesion is. In neuroimmunology, in demyelination, with time, the second and third MRI may not give you the correct picture. It's the first MRI which gives you the correct picture. So another lady, 35-year-old, lower limb weakness 2015, progressed over 3 months. cranial nerves normal, spasticity in the lower limbs. So you can see here there was not a sensory level, but here if you see there is a hyperintensity which is going here almost 2 segments, and here there is more than 4 segments. So what is a clue here is if you actually take this 3 and more than 3 segments, you will make a diagnosis of LETM. But the clue was the progression over 3 months. Your primary demyelination, MS, NMO, MOG usually do not progress over 3 months. So when you get a progression which happens over a long period of time, except for the progressive form of MS, always think of some other inflammatory disorders and immune mediated disorders or a connective tissue disorders. So for example, this patient, we had not seen the first MRI but saw it later. So you can see here there is a subpile involvement of the contrast enhancement. This I have taken it from continuum series because my patient did not have the full classical form, but otherwise this is the trident sign which can be there, and this is a case of a neurosarcoidosis. So LETM, you can see it can be vascular, it can be demyelination, it can be inflammatory. So even on the clinical, you will be able to tell as to whether you need to go towards which, because sometimes we may not have the full images and the full panel of test. So this is a man. So you can see here, the moment you touch, he's having this type of episodes. So basically, he came because he had lower limb weakness, which had improved, but continued to have this. This is another lady. What are these? Whenever she's trying to get up, she observes that there is so much of pain and she's not able to move. You can see her, she's not having 0/5 power, her power is 4/5, but when she tries to move, she's having these type of pain. So these are tonic spasms. Remember that these tonic spasms are very, very important to recognize, because these are the ones where you have axonal damage in the spinal cord, and axonal damage usually has because of a NMO spectrum disorders. So finally, what I would want to tell is, in optic neuritis, always clinical is very important. Even if it is the first episode, you see whether it is unilateral or bilateral and what is the severity. For example, you may have a visual acuity of 6/6, 6/9, 6/12, which improves spontaneously or even without steroids. Those usually goes in favor of a primary demyelination like MS. But if you have a patient who has 6/60 or complete perception of light, even in your first episode, and if you do not have your antibodies, these goes in favor of your NMO spectrum. So that is the reason your severity of the visual dysfunction is very, very important in cases of optic neuritis. And these you should not treat them as a single episode, but treat them as a spectrum of the first episode of the NMO spectrum or the MOG-related disorder. And always imaging is important, especially in optic nerve. Here also you can make out between short and long segment and whether other sites are involved. Patient has come to you with optic neuritis, but if you see that there are plaques or there are white matter changes in the brain or the spinal cord, yes, you will be making a diagnosis of MS or NMO at that point of time. So it is not that you will be only looking at that site, but you'll also look at other site of involvement. And the therapeutic response, you have given steroids, patient has not improved, please do not stop at that time of point, because eye is definitely important. Eye is time, eye is very, very important. So steroids, they have not improved, always to give a trial of plasmapheresis. And if you're thinking of MOG like disorders, IVIG is important, only then step up towards plasmapheresis. Same thing with LETM onset, whether it is acute. I showed you about the acute, vascular, subacute, demyelination, chronic being inflammatory disorders. And always look whether it is just an infective cause or a post-infectious causes. Thank you.